covering the stories that impact your life, your town, your state, and your future. This is the Means Report with your host, Brad Means.
Hello, everybody, and welcome once again to the Means Report. We certainly appreciate you spending part of your day with us, where today we're going to focus on a couple of wonderful projects going on right here at Wellstar MCG at AU, projects that really could end up helping a lot of people out there, beginning with spinal cord patients. A lot of those folks experience a lot of pain, and there's an effort underway right now to come up with a drug to reduce that pain. Also, it's tough to get health care to people sometimes. Sometimes they live in rural areas. It's not convenient for them to go to a doctor's office, so we turn to what? Telehealth. And there's a big effort going on right now at MCG to get that care to OB patients. You'll want to stay with us for our second segment where we will focus on that. And then, of course, we'll wrap up the Means Report as we always do with ways that you can stay in touch and help us get more great guests like Dr. Laura Carbone. Dr. Carbone is the Division Chief of Rheumatology at MCG. Yes, I know it's Wellstar MCG at AU, but let's just go with MCG for the purposes of efficiency during the next 11 minutes or so. And Dr. Carbone, you're leading the research, the investigation into coming up with this drug for spinal cord patients. Thanks for doing that, and thanks for being here today.
Thank you for having me.
All right, so this study is being funded by a $3.2 million grant from the Department of Defense. I thought that was pretty impressive, but I was curious, how did you get in touch with the Defense Department to get them to give you that money?
So the Department of Defense puts out a number of announcements every year for priority areas for research, and one of their priority areas is persons who have a spinal cord injury. So we answered a priority area for a trial for patients who have a spinal cord injury.
This study is personal to you. Tell us about your connection to someone with a spinal cord injury and pain.
Yeah, so unfortunately, this neuropathic pain is a very debilitating condition. It's a condition in which one may describe it as burning pain or pins and needles type of pain, and it's very difficult to treat. And I had a family member who had a spinal cord injury and did suffer from neuropathic pain. So it's very personal to me, and I'm really hoping to find a drug like this that will help these patients.
I'm sorry to hear that, first of all. When you say pins and needles, is it as if my extremities are asleep? Is it that feeling, a hand being asleep or a foot being asleep?
In the case of this study, we're looking for persons who have a spinal cord injury who have neuropathic pain in their lower extremities, so it would be in their legs, and it would be as if it's asleep. Sometimes persons will describe it more, though, as tingling or burning or very painful burning sensation. And for this study, it's below the level of the spinal cord injury, so the pain would be in the legs.
What kind of trauma do you predict will have befallen most of these study subjects? Is it something that happened perhaps in the military?
Sometimes it could be in the military, sometimes it could be outside the military. So most causes of traumatic spinal cord injury are either from a motor vehicle accident, it could be a gunshot wound, it could be a fall. There's other causes, but those are the most common.
So what happens if somebody's watching right now and says, oh my goodness, there's a possibility of pain relief? How do I sign up?
Yeah, so this is a trial that's, as you said, being conducted at MCG, Augusta University. So we have a number that persons can call if they're interested in the study. And then when they go into the study, we'll find out whether they qualify. So we'll ask them questions about their pain. And then we will go ahead and we will do things such as a medical history, a physical exam. They'll have some blood tests done, and then they'll have some tracings of their heart done. And if they are interested in the study, those are all things that will occur during the study, but first and foremost, they will come in and we will talk to them about the study, and they will sign what's called an informed consent. And they will receive either this new active study drug, which is not commercially available, or what's known as a placebo, which is an inactive tablet, because we need to find out if this works or not. So they'll be contributing to the science to understanding whether or not this drug is effective.
So you have the actual pill?
Yes, we have the pills.
How often do they have to take it?
Yeah, so in this study, they'll be taking it for 14 days, and it's given as a pill, and it's a different dose for different days, so it's one time during a day that they'd be taking it, though.
Have you tested it on animals yet?
It's been tested in animals and has been shown to be safe. It's also been tested in healthy human volunteers, and by that I mean persons who don't have a spinal cord injury, and there were no serious side effects.
How can you tell if an animal is experiencing pain relief?
So there are conditioned award systems that one can look at. So in animals, it's obviously a little bit more difficult than humans, but there are ways to look at it.
Talk about the duration of the dosage is 14 days, and then after that, is there anything that the test subjects need to be concerned with? Are you going to watch them after that?
Yeah, it's a very good question. So they receive it for 14 days, but they're in the study for a total of 42 days. So they are watched after the study, and after the study, they come back, not every day, but periodically they'll come back to the study center and we'll do more testing. And by that I mean more lab testing and EKG, and ask them how their pain is doing.
How long does it take? Because what you're saying is so exciting, but I'm sort of tempering my excitement by saying I bet it takes forever for something like this to get to market. Can you sort of give us a feel for that timeline?
So this is a small study to start. And if it shows safety and efficacy, the next step would be a larger study. So we could be several years away. But this is the first step in something for a disorder that's very difficult to treat. So it's a first and very important step.
Are all of your researchers under one roof down at MCG, or are they all over the country?
So anyone can come, but because for this study you have to come for 42 days, at least periodically, and for several of these days you have to stay overnight at Augusta University. In general, it would be easier for persons to be coming from our local area, but anyone is welcome, but they would need to understand that they'd be essentially here for 42 days.
Do you pay them?
They are paid, so they are compensated in part for their time. So if they complete all of the study visits, for all of the study visits, they would get a little bit more than $3,500. That is not nearly enough to compensate somebody for all the time that it would require them for the study, but it's some small offset. We also provide meals for the days that they're in the study for a long period of time, and for the days that they're overnight.
Well, and if it's successful, Dr. Carbone, you really can't put a price on that, right?
That's true. And anybody here who's listening who has neuropathic pain from a spinal cord injury absolutely knows that, because we don't have great drugs yet.
I was going to ask you about that. What's out there right now? If I have a spinal cord injury, God forbid, and I have the neuropathic pain, what am I taking?
So for this study, persons who are taking opioids, that's narcotics, are not going to be enrolled in this study. So we're taking persons who are not on narcotic medications, but they can be on other medications for their pain, for their neuropathic pain, and those will be continued. So drugs like Lyrica and gabapentin, those are drugs that are commonly used for neuropathic pain.
Why can't you take the opioid patients if they agree to take a break from that?
So we don't want to stop anybody's medications for them if they're not on it. They certainly can be in it, but we're not going to ask people to stop medications.
So this new drug, I'm guessing, is opioid free.
It is opioid free, and in the animal models you asked about earlier, one of the really good things that we've noticed is that doesn't appear to be any potential for addiction. And we all know with opioids, that's a potential problem.
I was going to kind of step back from the study and just look at opioids in general. Do you still see a huge problem? We've done so many stories where we're hopeful that we're putting a dent in the epidemic. Are we?
I think with people like you and public awareness being there, I think we're doing a lot better. And I think that with the availability of some other treatments for that, we are doing better. But we're still by no means out of the woods.
What other rheumatological issues do you see in your practice? Are we talking lupus and other issues like that? What are people presenting with these days?
Yeah, so not for this study,
right.
Because persons who have other conditions this is only for people with a spinal cord injury, but you're absolutely right. We see, unfortunately, a lot of patients who have lupus. We see a lot of patients who have rheumatoid arthritis, some patients who have osteoporosis, and a number of other connective tissue diseases. But unfortunately, there is a lot of lupus out there.
What's the best case scenario? We'll go back to the study now and talk about spinal cord patients. What are your hopes and dreams that these folks, when you're finished, and if we fast forward a few years to when the drug's on the market, Dr. Carbone, that they're pain-free? Is that the goal?
That would always be our ultimate hope.
Yeah.
But if we could make a dent in their pain, if we couldn't do it 100%, but we can make a substantial difference, that would also be extremely valuable.
So go back to the impetus in your life that we talked about at the top of this, the catalyst that led you to do this research, your personal connection to a family member with spinal cord pain, with neuropathy, neuropathic pain, forgive me. How does it make you feel to know that you're doing this on their behalf, really, and that it's making progress and you have a lot of money to work with right now?
It would be for her and for so many people potentially life-changing. And for me, the only reasons I think I became a doctor was honestly to help people. So if I could make a small difference, that would be outstanding.
Well, I am claiming it. You're going to make a big difference and you're dedicated to it. And so please share my gratitude with your team. I appreciate you so much.
Thank you. We really appreciate you having us here.
Absolutely. The door is always open. Dr. Laura Carbone from MCG, Beach Island, South Carolina's own Laura Carbone. We appreciate you being here today. We love our Beach Island viewers, and we appreciate you finding out more about that study. And if you know somebody who can benefit from it, use the information that Dr. Carbone has talked about and get them to sign up. When we come back, we're going to talk about OB care and delivering it to people who might otherwise not be able to access it. It's all about telehealth. We'll talk about it in a moment. Welcome back to the Means Report. We appreciate you staying with us. Thanks again to Dr. Carbone for giving us such great information about her study. I really hope that people watching are able to take advantage of that. And as she said, be pain-free one day. Wouldn't that be wonderful? Another thing that is wonderful that is going on at WellStar, MCG, at Augusta University is the effort to make sure that women who need OB care get it, no matter where they live and no matter how limited their access to a healthcare facility may be. And a gentleman who is helping to make sure that happens is joining me now. He's Dr. Matt Lyon. Matt is the director of the MCG Center for Digital Health, also a professor of emergency medicine. Thanks for what you're doing for these women, and thanks for being here today.
Yeah, thank you for having me.
All right, so the first thing I noticed when I was looking at your title was that you lead the Center for Digital Health. That sounds like something that may have been born from the pandemic. Is that accurate?
Well,
and what is it?
The center is part of MCG, where we do education and research when it comes to telehealth and telemedicine. And partnering with WellStar MCG and WellStar generally, we are able to provide services across the state of Georgia through digital means, telehealth, digital monitoring, those kind of things.
All right, so go back to the pandemic, and since March of 2020, have you seen an increase in more patients going, you know what, maybe I don't need to drive to the doctor, I'm just going to FaceTime him or her?
Well, we began telemedicine actually a couple of decades ago, and it's been expanding, but the pandemic had an interesting effect on digital health. What it did is it allowed people to be exposed to it, and then it became an acceptable means of obtaining health care. And what we were doing during that time was expanding our rural services to get people in rural hospitals tied to our academic medical center for specialists they wouldn't have access to otherwise. And so the pandemic allowed for us to create what we call the Digital Care Network, which is 19 rural hospitals across rural Georgia that are tied into WellStar. And we're able to then tie in emergency physicians, critical care physicians, OB physicians, infectious disease doctors, all kinds of specialists, so that those patients don't have to transfer or travel from those rural hospitals or those rural counties to Augusta, and yet they're still seeing that specialist and getting that specialty care.
All right, let's talk about this grant that is helping make the OB expansion in telehealth possible. Where did it come from? How much is it? And how will you spend it?
Well, it's a very interesting grant. So our rural network tells us where the gaps are in rural healthcare. And so one of our hospitals said, you know, a lot of our hospitals have given up delivering babies in rural Georgia. And so moms have to travel a long ways when they have an emergency. And as you know, an emergency, time means a lot.
Yeah.
So we began exploring that, and we found out that there were some simple things we could do beyond what we already do about tying our specialists into the rural hospitals, providing some equipment, providing some training and guidance and protocols. And so we embarked on creating what we call the OB network, or the Tele-OB network. And what that means is that we're tying our rural hospitals in to see our emergency OB providers 24/7, 7 days a week through digital means. But we're also giving them some equipment so that we can evaluate mom. And we're giving the ability to tie that back into our electronic medical record so our specialists can see that just like they were standing next to the patient.
Okay, so let me go back to that because I think we really need to make this clear. It's the rural physician talking to the physician on the other end.
It is, and our physicians can see the patient, so they can build that patient-physician relationship, but we work in conjunction with the physicians and the clinicians in those rural hospitals.
Okay.
And so they are key partners. So it's clinician to clinician talking about that patient, and that patient's getting tied into the specialty services they need, getting those specialty tests read, getting those ultrasounds done remotely, so that maybe the mom doesn't need to transfer, or if there is an emergency, that it's expedited so they can have the best care possible.
Is there ever involvement by the patient in that telehealth experience? I know you mentioned it's doctor to doctor. Can the patient go, wait a second, you forgot that I'm feeling this right now?
Yeah, that's the beauty of this, is that it's almost like beaming in the room like we're here on TV.
Yeah.
And so they can interact with the doctor there, the doctor on the digital means, and they're able to review test results together and make a cohesive plan that's patient-centered.
All right. You've alleviated my apprehensions about telemedicine as far as, they can't physically touch me. They can't look at my issue face to face when you're doing telehealth. What would you say to anybody else out there who might say, look, I don't care what you say, I will never not physically go to the doctor because I don't trust those cameras?
Well, again, this is a special kind of digital health where there's a clinician there taking care of you in person, looking at you face to face, able to touch you, take your blood pressure. You have a whole team there in the rural hospital, from nurses, pharmacists, doctors. What we're doing is bringing in that specialty care. So bringing in that added bit of benefit so that you don't have to have any ambiguity in your care. You don't have to transfer and go see that person face to face. So it's really a beauty because it's getting the right care to the right patient at the right time in the right place.
How long, let's just stick with pregnancy, how long during the duration of a pregnancy can this sort of virtual relationship go on? Is there a time where you cut it off completely and say, ma'am, let's get you to the actual doctor?
Well, again, so the program we have is we can do this 24 hours a day, 7 days a week to our 19 rural hospitals with any clinician.
Sure.
For OB specifically, what we want is for those rural providers, when that mother shows up in the emergency department, to say, I think an obstetrician could help fill in some gaps to help provide a little bit of better expertise and tie into that network so that our OB provider is helping take care of that patient. Because there's many of our counties that don't have an OB provider. And while they have good primary care physicians, they may even have some emergency physicians, they don't have that OB specialist. So this is bringing that OB specialist into the room to make sure they're getting OB specific care.
So would that OB specialist, for instance, be able to observe an ultrasound while it's live, or would he or she just get the film of it later, but live and say, okay, here's what I'm seeing on my end. Does that happen?
Yep. They can look through the digital means. They can help guide the ultrasound. So if they're looking at something specific for what that mother came in for, they're able to see that and get that real time. They're also able to evaluate the mother with that bedside ultrasound. So it's even more powerful than just getting the images coming back in your chart, because you're able to ask mother questions about what you're seeing. Is this where you're hurting? Is this a problem? How long has this been going on? While you're seeing inside their body.
Dr. Lyon, I think you mentioned at the top of this interview, maybe 19 rural hospitals that can be connected via WellStar. How do you determine the need? How do you know, hey man, this area is underserved? Is it just all looking at numbers, data?
Well, I mean, from what we're trying to do, we'd love to tie in every rural hospital in Georgia. We're about a third of the rural hospitals in Georgia are tied into us. But, rural hospitals in general have needs, and what we bring to them is a menu of services, a menu of specialists, if you want to think of it that way, where they can have easy access to the care that they need, the specialty services they need, without having to travel to Augusta or Atlanta or wherever. Staying in their rural communities is really important for us, helping keep people in rural communities, decreasing the burden, cost of care, helping them with their chronic diseases, helping them in their acute emergencies is really what we're trying to do.
Just from a technology standpoint, how clear is the telehealth connection? Is it just like super HD, or does it buffer like sometimes we experience at home?
Well, we always hear about the rural broadband issue, and that is a problem. However, these are in the hospital. So our hospitals are digitally connected. They have really good internet service. And so our 8 and 10K cameras, we get really good images.
Does insurance kick in for any of this? Does it need to kick in for a virtual visit? Kind of walk me through that. That's a concern.
Yeah, so, in Georgia, we have really good state legislators that have made telehealth really good, because we have an enormous state and digital is one way to reach all of our populations.
Yeah.
And so they've made it very good. So we're able to bill for our services when we see that mom. The rural hospital is able to bill also. And the mother is also saving money, because oftentimes she would have been transferred and had to come, an hour, 2 hours to Augusta or Atlanta or Macon, and then had to get back home.
Right.
And so actually this decreases overall cost of care for both the state, but as also to the patient.
How secure is it? Should I be concerned that during a virtual visit, when my doctor and the doctor on the other end are discussing my private information, someone's going to hack into it?
Nope. This is all secure, HIPAA secured, digital means. And the way that it works is that it's coming through the hospital. It's a hospital-hospital connection, so nobody can tamper with it.
Can I ask you just a couple of general questions?
Yeah.
And I appreciate you walking us through the OB telehealth push. I hope it continues to go well. But what about ultrasound? We talked about it during a woman's pregnancy. Are you seeing ultrasound technology used to diagnose other issues in the human body? And if so, what can it do?
Absolutely. So point of care ultrasound, or ultrasound at the bedside by a clinician, is something we've been doing for almost 2 decades at MCG, and we're able to tie that into the rural hospital. So we provide them with the equipment. It comes through that same digital network, and so we're able to see those images live. Our grant was part of a USDA grant. Mm-hmm. It's also provided ultrasounds for rural hospitals, as well as the digital communication, and now providing this OB-specific equipment. We also had the Georgia Community Foundation, which gave us a grant that really helped us leverage the USDA. The interesting thing about federal funds is oftentimes you have to have a match.
Yep.
And so the USDA provides 85% of the money you request, and we used the Georgia Community Foundation for the other 15%. So we took their 15% from Georgia and multiplied it. And so we're able to provide, this grant's about $450,000 of equipment for rural hospitals. And we've been able to use some other foundation funds to get that to what we really need to do to equip Georgia's rural hospitals.
Well, I hope that you are successful in that effort. I know you will be. And on behalf of the patients out there and the doctors who benefit from it, thank you for what you're doing.
Thank you.
Absolutely. Dr. Matt Lyon, MCG, a wonderful effort going on right now to expand healthcare and improve it to those who might not be super close to a doctor or a hospital. When we come back, we will tell you how to stay in touch with us here at the Means Report and help us get more great guests like Drs. Lyon and Carbone when we come back. Won't you please stay in touch with us? We love to hear from you. What did you think about this edition of the Means Report? Who would you like us to have on next? You can email us, meansreport@WJBF.com. Just put the Means Report on the subject line. You can also follow us on social media, all one-word address, The Means Report. And you can watch our previous episodes on our website, WJBF.com/The Means Report. Again, please stay in touch with us. We get those emails, and it's interesting to hear your perspective. I learned a ton today from these two doctors. I hope you did too. For Jarrett Ledger, always Marlena, and the entire Means Report family, take care.